All right. So thanks again for everybody joining. We really appreciate. We know everybody's super busy, so we appreciate you taking the hour to join us. We have a didactic presentation today from Danielle Tacker, who will be leading us off. We don't have an official case for the session, but we'll obviously do Q&A with Danielle's presentation, but we'll also, if there's other things that you have questions about that maybe aren't necessarily related to the didactic or anything, please feel free to raise those. You can wait till the end and unmute and talk, and ask your question. You can put it in the chat. I'll be monitoring that and we can review them later. So it's really your preference. Are there any questions before we get started? Any technical issues with the new iEcho? They've done some updates which have then triggered, it's like when you plug a leak in one place, another one spouts. So is there anybody have any issues getting on, or the reminders or anything like that? Just wanted to check real quick. If you have any, go ahead and put them in the chat. I'll log them. Just wanted to double check as they are kind of making some updates to the system. So without further ado, I will turn it over to Danielle, and go ahead and take it away.
Thank you. Thanks for the invitation to come back to talk to the Echo group. I've talked in different forums, and you can see thumbs up if you can see the presentation. Good. Okay. Thank you. So Danielle Tacker here. I am a professor of pathology for WVU, but I work in the hospital at Ruby. I work mostly in the kind of medical director sector of this laboratory, and I'm the medical director at the Fairmont Laboratory. My section includes mass spectrometry, which is where we do the definitive toxicology testing, and through the years just have helped out with toxicology questions and kind of learned by hard knocks and case reviews. So there's a lot of things that can come up. I have a few slides. I have 29 here in the deck. Probably 20 of them are content. And then I figured that we could do anecdotal or other discussion topics after I was done. So I intentionally kept it on the half side of the hour. All right. So I have no disclosures. Jedi mind trick, there's no conflict here. I don't even need the Jedi mind trick. I don't sign contracts with vendors so that I can give honest opinions and feedback to people. So that's just kind of a policy I have. And we'll start out lead in with some terminology. And I've done this talk several times, so some of these slides may look familiar, but I've kind of mixed in some new content. So if you've seen it before, there might be some new elements coming to you. All right, so the first bit is terminology about testing in its own right. What's a screen versus what's a confirmative test versus which is a definitive test. And this can get right out of the gate, this can be kind of a muddy topic. So I kind of compare the basic characteristics of testing here. Screening, you're going to have a presumptive qualitative result most of the time. It's going to be, is the drug here, yes or no? It's kind of a binary. There are very few quantitative screens in the urine drug testing world. If you're looking for something like a therapeutic drug monitoring test where you're looking for compliance in a serum and it's well characterized, then those types of tests are more in the definitive class. So that moves over one. These tests in the screening world could be rapid enough to be in a cup in 10 minutes, or you could send them to my laboratory and we're done with it in about an hour. If you have access to mass spec-based screening, which is a really cool new tool, and it's at some very limited centers, the analysis is really fast, but getting the sample to the destination and having them work it up, the time will change a lot depending on that. So the utility of the test, what you're aiming for, all of these things influence what kind of test should be selected up front. And like I say here, the screening test usually qualitative. You move to the middle here with definitive testing. Definitive testing is just that. It's more based on a positive identification of a discrete compound. So it's usually the technology in the background is usually mass spectrometry. I would lump some of I just said it, therapeutic drug monitoring tests. Some of those are immunoassay based and they're quantitative because they're calibrated and everything, but we're often talking about mass spec in the world of drug screening and testing. So there's a bunch of different methods. I'll kind of go through a little bit on that. I don't want to go too deep on the methodology, but it's usually going to employ something that takes it up a notch, right? So you're getting to the compound level. You're often looking at metabolites. You're often getting a semi-qualitative or a semi-quantitative signal. So if it's below a decision point or a cutoff, it will be negative, and you'll only get that qualitative response back. But if it's above a decision point or cutoff, it could be something that is numeric in its reporting. So definitive moves into that kind of quantitative area. When we're talking about how it's usually used in compliance testing settings. So you skip the screening. I know the patient should be on this. I'm going to test directly for it. Definitive methods are used for that. And some other applications that you can see here. And then confirmatory testing on the far right. This is in the legal world. This is going to be mass spec based, or it starts with an immunoassay, gets screened, and moves to mass spectrometry. It is calibrated. It is every compound, and it's usually starting at 0. So if any is detected, it is reported. The laboratories that use true confirmatory testing go to endpoints. So if there's 50,000 units of drug there, they keep testing until they hit 50,000. Whereas in definitive testing, we go up to an upper limit and we stop. We just go, you know what, it's greater than 1,000 because there's a lot here, you know. So it depends on the setting, what kind of regulations are present in the lab. We call it confirmatory / definitive in my laboratory because we're confirming the presence of a compound. It's not on the forensic level of true confirmatory testing. So there is some double use of that term. But this table isn't meant for me to stick with it for many minutes because I want to get to some concepts. But I'm happy to share the slide deck with you so that you can read through it and study it as you need to. All right, so immunoassay is often used for drug screens, particularly in urine. Many of the serum tests are going to be immunoassays. And so what we're doing is we're employing our own kind of biological products. We discovered antibodies and what they're doing in the early 1970s. And very rapidly, people said, hey, we could use that as a detection system. So we actually take monoclonal antibodies from mice or polyclonal antibodies from goats, horses, other animals. These antisera are just antibodies that we can engineer and put into assays to detect what we need. And very important to immunoassay is this concept over here on this left top bit, the antigens. These are fragments of or entire compounds that fit into the little notch that's labeled antigen binding site on the antibody. And if it's got a direct fit, like this yellow antigen, then you've got a really strong connection and you've got a really good hold on it. But there might be a couple of other things in this blend of antigens right here that could potentially fall into this pocket and also give a positive signal, and that's cross-reactivity. So a risk with immunoassay is that you could basically introduce something into that analytic system that could give a false positive result, which is why we often recommend, if you really need to know if something is present, if you get a positive screen, you move to a confirmatory method or a definitive method, because you kind of need to know what's there, particularly as the risk and the medical legal use implies it, right? So, you know, this is just kind of your initial, yeah, get a signal. And I wanted to parallel size here, that what the size of an antibody is versus what the size of its antigen is in terms of drug testing. Drugs are extremely small in the world of antigens and immunoassays and how they work. So this whole thing is a therapeutic IgG antibody. It's 150,000 Daltons. And I don't know if you remember your chemistry class, but the Dalton is, you know, 1 unit. So 150 of those, that's a lot of molecules that are being bound together and put into this, because each of these little circles is a peptide. And the peptide is bigger than this guy right here. So this is paracetamol, so acetaminophen, Tylenol. If this antibody were supposed to bind this is how big it would be over in this tiny little shadow at the base of the cone in the magnifying glass. That's the actual size of the paracetamol. We're magnifying it so you can see the structure here. So it is so easy for something else that looks a little bit like paracetamol to cross-react and bind with that antibody, because there's just so much structure there to house it, right? So this is a definite kind of pitfall of immunoassays. It's why they are okay for screening, but they're not great for definitive type testing for drugs. Then we move into the world of mass spectrometry, and mass spectrometry is most commonly used as a confirmatory method in modern medicine and medical legal use, right? So there's a number of abbreviations and hyphenations, and it gets really technical really fast. But in the end, it's about sorting and counting. And what I was trying to find was an image of a pile of coins. And this was a parallel that I saw a microbiologist give when he was introducing the idea of mass spectrometry-based micro. You have this pile of coins, quarters, nickels, dimes, pennies, all mixed together. And mass spectrometry is able to sort those out into their components, right? And it's able to say, I have 10 pennies here, and I have 5 nickels, and I have this many dimes, this many quarters. It's able to do that very rapidly in microseconds. So we've got this ability to take compounds from a biological matrix, a urine, a serum. We're able to put them into a mass spec, and it's able to do that. It's able to gather information and sort through what is there and count it for you and give you that return. So that's where you start getting into the world of more quantitative assessment, more definitive assessment, because it's able to say, not only is that a penny, I know it's a penny, and I know there are 5 of them there. So that's where we go with mass spec. The front end separation steps can be different. ICP is called inductively coupled plasma. It is the new way of doing elemental analysis in toxicology. So if you've got an arsenic detection or a lead or cobalt or something like that, in a case, it's probably going to be ICP-MS that's going to be the method used. And so you've got this torch that burns up the sample, the metal goes through, and the mass spec detects it with very high accuracy and gives you a quant. GCMS, most people have heard of GCMS because it was the very first drug confirmation method that was out there. It came up in about the 1970s. It became relatively common. And for many years, it just kind of plateaued at GCMS. GCMS can be problematic in its technicality because you have to force a compound that isn't usually volatile to become volatile. It's very toxic. It involves toluene and some other chemicals. You have to cook the sample with these things to make them go into a gas anyway. So you basically stick it in an oven. The top thing over here on the right is a gas chromatographer mass spectrometry institute. So it's an oven with a column doing separation. And then you do your mass spec, your sorting and counting layer. The one below that is the idea of some sort of chromatography that's like liquid chromatography. You're going to, again, separate things, and then you're going to pick what you want to look at in the mass spec, or maybe not, feed it all in and let it do its work. And then at the very bottom, that figure 8 thing that looks really super cool is the newest technology called high-res mass spec. And high-res mass spec is you put something directly into it, and it looks at everything that comes through. And it's able to accelerate particles through this figure 8 thing, and the speed that it makes it through that chamber is proportional to its size, and you're able to count and look at size and all of these really cool things. So I get really geeked out about mass spectrometry. It's always been a love of mine. So if you ever want to talk about it or come see what we're doing in the LCMS world, I'm happy to show you. But that's as much as I should probably say right now, because I'm probably going to get some glazed looks if I continue on about it. But basically, there's our coin sorting thing. I ended up putting a little machine into it. But yeah, the idea of dumping things in and it's putting it into outputs for you is the whole goal. All right. And another word you might hear is library. And this does involve the mass spec based analysis. So at the top right is an image of a mass spectrum. It's what the output is when you do your sorting and counting. It says, okay, I have this much intensity of this particular compound. I have this much intensity of this thing. And what it does is it takes this whole readout and compares it to an electronic library of files that match other molecules. And it says, oh, I have a match. Your mass spec at the top, the red, and well, it's in the bottom corner now, matches the blue in the library. So it's got to be this compound. This is the fingerprint that we have. So you can feed something in on into a library, and you can identify down to the compound level for thousands of compounds in milliseconds. It's rapid, it's great. And forensics has been using libraries for many, many years. It's now circling back in and making it to screening methods in some limited medical centers that have advanced chemists who are much better at mass analysis than I am. They're super wizards when it comes to this stuff. They're really good at it. And so you might hear a library now and then if someone's rattling something off to you. All right. And then the concept of cross-reactivity I already talked about briefly, but it's that idea again that when you've got antibodies in an immunoassay configuration, or you have chromatography without antibodies, but you've got a matrix of a column that's doing the separation for you, different things that have similar shapes or configurations could end up interacting with that system and giving you that positive result. So I press a lot on cross-reactivity because it is so commonly a cause of false positive results in immunoassays. It's the main reason that an immunoassay would give you an unexpected positive result. So it's always about what else is present. All right. And then an example, and I had to put some structures in because I'm a chemist. It is who I am. The concept of cross-reactivity, what I have on the left here is from my package insert for my opiate screen in my laboratory in the main part, the automated section that does the screening. The cutoff is 300 nanograms per mil for my opiate test, and the calibrator is morphine. So morphine is over here to the right of the box with morphine on it. Okay, so that's the structure of morphine. And if you look at codeine, you see that the structure looks pretty similar. It doesn't take a chemist to see that. You know, you've got the 4 kind of honeycomb boxes at the nucleus of your morphine, and you look over at codeine and it's got the same thing. So you would say, if someone called me about, is there a potential cross-reactivity here? Yeah, codeine could definitely do that. And we see that. Actually, codeine interacts better with the test than morphine does. And that's what this concentrated tested column tells us here. 6-monoacetyl morphine is heroin, the primary compound, right? At 280 nanograms per ml, just below the amount that morphine gives a positive result. You'll also get a positive from heroin. Go below that, codeine at 180. So almost half of the signal needed for morphine to give a positive in this test, codeine is going to trigger it even sooner. So you don't need as much codeine on board to give you a positive screening result here. You get to the bottom of the list and you get to some other compounds. Ranitidine is at the bottom here. And you can see the structure looks basically nothing like the morphine. And it took 500,000 units of ranitidine before it ever triggered a positive result on the opiate. So you'd have to drown the system in ranitidine to give a false positive with it. And then I show fentanyl because it's a group, it's in the opioids group, but you can clearly see that the structure of fentanyl is not like morphine at all. It doesn't cross-react with the test system. So that's why we have a separate fentanyl screening test in our drug screen panel. This is why we have 4 different opioids in the urine drug screen. We have oxy, we have opie, we have fentanyl, we have methadone, buprenorphine, 5 of them. We have 5 different compounds there because the structures are different enough that they just don't play well with the opioid tests or opiate tests. So we've got to have these different ones. So anyway, this idea of cross-reactivity can be a plus or a minus. You could get a false negative from this test. If you have a patient on oxy that's on a low dose and you get a negative opie, you're like, why? It's because they're on oxy. They're on something that doesn't cross-react. If you look down, 10,500, you got to have a lot of oxy present to make that opie positive. We do see it. It's usually with what we call simulated compliance. Anyway, so moving on. So this is the illustration, moving to another table because I love those too. Structures, tables, and spreadsheets. You know, if you ever want to give me a birthday present, those are the things to kind of come after. Doing this illustration about cross-reactivity and trying to hit it relatively quickly. If we have codeine present in the urine, we've already established that it could create an opiate positive screen, and it should. It cross-reacts. It's in the group. It's an expected outcome, right? We move it over to my LCMS-based test, we could find that there's codeine and morphine present because codeine is metabolized to morphine. It's not that they took 2 different compounds. It's that we've got a natural product of codeine coming through, and we would call that a codeine signature. And in a confirmatory test, it would say that there's codeine at 432, there's morphine at 200. Oh, and I found norcodeine too. I don't look for norcoding in my definitive method. I don't have that to report to you. But in a confirmatory test, a true medical legal confirmatory, they'll find everything related to that compound. And they'll say, yeah, you've got yourself a really strong coding signal here. And a good toxicologist could read it and be like, yeah, it's fine. Oxycodone, if we get an opiate positive and an oxy positive, like I said earlier, it's probably very high. So we could have an oxycodone at 650, a noroxy that's through the roof because it's the primary metabolite of oxycodone, so it's very high. And then an oxymorphone at 1250. Oxymorphone is a primary metabolite of oxycodone. So my method is trained to look for those three things. It finds those three things and it tells you these bits of information. If we had sent it to a medical legal lab and they went to endpoint to get a number on any compound present, we might find out that noroxycodone is 5,480. So these are the differences between these illustrations. And one more that I want to illustrate is right below it is carfentanil. Because the fentanyl derivatives are a big deal right now in the not only the realm of medical use, but also the forensic, kind of law structure of things. Fentanyl derivatives are not always tested for in laboratories like mine. I don't have any in my fentanyl confirmatory method. I only look for fentanyl. So in this case, our immunoassay-based screen does not cross-react with carfentanil. It'll be a fentanyl negative. Oxy will be negative and opiate will be negative. All of it will look negative. And the care team may go, that's an unexpected negative result. Could you confirm that? Well, we'll take it over to our opioid panel, which is 28 different compounds. And we'll be like, yeah, we didn't find anything. Sorry. Well, if you'd send it to a forensic lab with chain of custody, they could find the carfentanil. They could find its norcarfentanil derivative and its hydroxy. So it could say not only is carfentanil present, but it was metabolized by this person. So these are the levels of exactness. And there's two more examples there, but I'm just not going to keep driving that. I'm going to move on right now. All right. So the considerations when you're testing for drugs, then it's got to be, what do you test? How do you test it? And what's your intent? So the what is the matrix. And so the matrix, I have the definition at the top, is a natural and complete specimen. Hair is a matrix. Saliva is a matrix. Each of them has different components and proportions of protein, salts. The drug could be absent or present depending on how it moves through the body, where it might be stored. So the matrix is super important. Choosing the right one is going to determine what you can detect and how long. Okay. So in clinical lab testing, we're often using urine. And I have another table on the next slide that talks about kind of which setting things are popular, but you've got to think about how long things are going to be in different matrices, right? So if a person is acutely intoxicated, it's within minutes to hours of the exposure, probably blood or sweat or oral fluid are going to reflect something. But you have to catch it. You have to be really fast with this. And in most contexts, we're not going to get that kind of sample. And if it's in an oral fluid roadside sampling, a laboratory like mine cannot test that. It is off limits to us by our regulations. So it would have to go to a forensic laboratory. So you have to catch the acute stuff in the matrix at the right time. You move into days. This is why urine is used. It gives you a better picture. You're talking anywhere from 6 hours to about 3 to 5 days, depending on the compound and how it clears through the body. Urine is often a very approachable thing because it's also non-invasive, right? You give a cup, person pees, you get your testing done, right? And then in our setting in the laboratory, in the hospital, there's tissue. We do umbilical cords. We have a universal screening program that is not chain of custody. And every baby born, there's an umbilical cord. So we send that for drug testing because it's much easier to collect than neonatal urine. And there are some problems with a newborn's urine. It's very, very dilute on purpose. The kidneys are not working yet. So what you would need to use in terms of testing cutoffs in urine for a newborn is different than what you would use for mom when she shows up at labor and delivery. So anyway, umbilical cord is an option. It's depending on how it's ordered and sent, it may or may not stand up in court. And then meconium, we're at weeks to months of collection. Meconium is formed starting in about the 6th month of gestation and then goes through gestation. Problem with meconium is it can be discharged if there's fetal distress in the womb. So you might not get a sample there. it could take several days to clear. So often the baby is discharged and has voided the meconium before anybody can collect it. So it can be kind of a problematic matrix to collect. And then in people who are in chronic programs or other monitoring settings, you might see them get hair or fingernails tested. In forensic settings with decedents, you can look at teeth, bones, and other depots of potential drugs. So there's going to be a lot of things that can go on there, but you can detect out to years in some of these matrices. Okay, so then in those settings, I kind of rattled this off in the clinics where really there is some oral fluid coming up in some clinics. Serum and plasma, not so much unless someone shows up to the ED and they are acutely altered and they pull serum and they want some testing done. This is more often in the children's hospital than the adult ED. That could be sent out for testing. We don't do it here. We do mostly the urine testing in the hospital setting for the clinical drug stuff and the ED. And then on the floors, you can see here, there's a bunch of stuff. There are some question marks here because it's a matter of whether or not you can actually collect a specimen or get that specimen in that setting. They would probably test it if they could get it. And then in employment settings, you get into places where a few places do hair, a lot of them do urine, and then you've got some serum and oral fluid stuff. Police and roadside, you can see is breath and saliva often. They'll do blood if they follow a patient to an emergency department and they want to grab a chain of custody ethanol or something. They might do that themselves and we'll facilitate that. And then first response, you can see here. So what is tested, how and when, it's going to depend a lot on setting and whether or not we even keep that stuff around for very long. So the common questions that we get asked through the order itself: is a drug present? So this is in either a compliance or a therapeutic drug monitoring setting, in a drug diversion program, or if a toxidrome is present. So a patient comes in obtunded and it's like, do we have a depressive here? Do we have an opioid or something like that? We can kind of say a yes, no, and we can target that depending on what the team is looking for. What drugs are present? You could do a global screening test, like a urine drug screen, start with drug classes that are more common. And then you can also do some level of targeted testing that way too. And in abstinence checking, we're definitely seeing that through the substance use disorder and medication assisted therapy clinics. There's a lot of abstinence checks. Have you been drinking? No. Let's get a urine anyway and just double check it. They do that at random with a certain number of patients that are coming through clinic just to kind of check. Pain management, always looking for use of things that are not prescribed, just to kind of make sure that patient is doing well, stable. And incarceration avoidance programs, this is often going to be used. So we've got those two very common questions. The less common stuff is how much of drug X is present. You should never extrapolate a urine result to a dose. Don't do it. Please don't do it. Don't say that because there is 300 of morphine present that means the patient took 300 of it. That's not how it works. This is definitely dependent on clearance, intake, dosing formulation, a whole bunch of factors that we don't have in the laboratory. We don't even know those things. So often if we don't know those things and the provider doesn't know those things, then we're just never going to know. It's more, it's a strong presence. So it's probably kind of recent is more the answer. And timing is going to be pretty important to that. There are a few well-characterized therapeutic drug monitoring drugs where you can say, okay, I'm expecting my vancomycin to come back in this range, and above it is toxic and below it is probably ineffective, and I need to test that, and that's on an inpatient. We can do that. But this is not the setting that we're talking about here. We're talking about usually drugs of abuse. So, and then when did the patient say take the drug? We usually have windows for that. We can't say yesterday. We could say, well, this drug is usually found within this matrix, the urine, for about 3 days. So in the last 3 days, you probably had some kind of use pattern. So it will depend. And then again, the thing that we can't do is tell you what dose a patient took. It's just not something that we can back calculate. And someone would have to really know the pharmacokinetics, the pharmacodynamics of the patient, and a whole lot of other stuff to be able to imply that accurately. So I say, as we do on the right, we're better at the magic 8-ball responses in the laboratory. It's like, it's a pretty good chance that this has happened. It's kind of in the world that we live in the labs. That is not great in a medical legal sense of things, and we acknowledge that. So intended use versus evidence, wanted to get to that pretty quick. In the clinical world like ours, there's no chain of custody. Okay, we don't have the space to segregate all these specimens, to keep these logs. It is a lot of work for one person to even track an ethanol through that a deputy is going to come pick up in a while. It's a lot. So we realize that's a lower level of evidence. Do our people get called to court to talk about ethanol testing? Yeah, they do. But there's always a discussion about that level of evidence because there isn't a chain of custody on that. So this is super important. And when I use the word confirmatory in my world, I mean, it's a compliance check. It's like, yeah, they were supposed to take it, they took it, or they were supposed to take it, they didn't take it, or they were supposed to take it, they probably added it to the urine, they probably diverted it. Those are the kind of the buckets we have. So our intent is going to be medical use. And I think every single one of our toxicology tests says for medical use only. And we label it that way. And what you have to think about is that the people performing these tests are not actually toxicology experts. They are doing a test and getting an output and reporting it. It's very straightforward. They're doing a whole bunch of other testing. So metabolic panels, endocrine stuff. We're drilling through a menu of 200 or 300 compounds, not drugs. The drug screen is one small component of the business here. Compare that to your forensic setting where there's a full chain of custody and it needs to be maintained. Any break in chain of custody can weaken the evidence level. So this is key. You got to maintain that. Confirmatory in this world means you're doing fingerprint library searching and quantitative down to zero. Like you've got just a different level of stringency there. So the intent is going to be, it's going to go to court. Anytime you do that testing, you say this could end up in court as evidence and we need to make sure it's right. So the testing is controlled and run by people who are trained to do that testing, to understand it, to really look at the nuance of it and to analyze it. And they're going to come and report to court in a different way than someone from my world might do. So that's the contrast. And then there's still debates, even about blood alcohol. This abstract, I know you cannot read it. That's not the intent right now, but this is from this year in February. There's still studies going on about, well, how good of evidence is a blood alcohol test in a clinical setting? And they're still saying, well, there's some potential holes in this. So we just keep having the discussion over and over again, and it keeps coming out with a similar outcome. And it's because of these limitations in workflow and training and all of these elements that are traveling in the background related to drug testing. So even the blood alcohol test is still one, even though it's the classical test, it's the one that hasn't changed so much in ages, we still have to discuss that one. All right, so interpreting the tests, quickly, an anatomy of a screening result. You're usually going to have some kind of qualitative output, negative or positive, present or absent, something like that will be the terminology that you're going to see. And then if there's a result comment that comes with it in the legal record, it should contain a cutoff. This is what our regulations tell us to put into our reports. So it should be there. That screening results are presumptive, and that if you have a suspicion, that you should definitely confirm the test. So we don't say that this is the end all be all answer. We know that. We tell what the intent of the use is because that's what our labeling says. It's FDA approved for medical use only. Okay, that's what we say too. And then any additional information, and I have an example here. So we have a tramadol. We had a tramadol screening test and we turned it off because everybody was using the definitive. But you can see the output here. It says there's a tramadol, it's positive, it's intended for medical use only. Positive results are presumptive. The cutoff is 200 nanograms. So very straightforward. And we included creatinine with it to tell you about how concentrated or dilute the specimen was. The fentanyl here, we add a comment that labetalol and other beta blockers can cross-react with this method. We know it, so we just put it in as an interpretive comment. Consider a beta blocker if you don't expect this result. We still say, please go ahead and confirm it if you want to, but this was to help and protect OB patients that are on beta blockers to manage gestational hypertension. A lot of them are given beta blockers and they're always tested for drugs, and they were getting bunches of fentanyl positive screens. So we said, you know what? Every patient you've shown us so far is on a beta blocker. So the evidence is there. The molecules look the same. So it is a known cross-reactivity. So that's what we're going to give you. So the pitfalls, already covered it quite a bit. Cross-reactivity is going to give you false positives. It's going to do it. Lacking cross-reactivity, give you a false negative. You can get false negatives because you've got a person who's on a prescription at a very low dose, and they may perceive that it is an as needed prescription. I've actually hit that with benzodiazepine negatives. Patients on a very low dose and takes it every 3 days or so for anxiety. Well, that's not going to be enough to give you a positive, even with the definitive method. So it just keeps coasting in below cutoffs. The specimen is diluted either by medical condition or by adulteration. So the patient might be putting water in it because they're afraid that a positive will be a bad thing, or that they haven't put enough urine in the cup innocently, just added some water to it. I've seen that happen. And then cross-reactivity, if it's weak, like I said before, can give you false negative. So these are pitfalls, things to think of. When we look at the definitive test I use it as an example. This is a lot of small print, but we do a whole bunch of compounds. This is just the opiate confirmatory. There's more compounds if you get we call it the whole enchilada test, the toxidrome test. But we give you a drug signature. So our people are trained to look at the pattern of what comes out, what's positive and what's not. And they say, oh, yeah, this is consistent with oxycodone. So you don't have to worry about that oxymorphone because it's a metabolite. We know that. And we just say, yeah, this is consistent with oxycodone use. And then I have some rules that we follow. If the result is greater than a cutoff, we give a quantitative result. If it's less than cutoff, not detected. By regulation, we can't tell you what the number was below the cutoff. And then what the upper limit of quant is. So it's 1,000 for much of our stuff because that's plenty to get you on your footing. And so we get a lot of greater than 1,000s. And so in this case, it's labeled as definitive / confirmatory. It's not a true forensic confirmatory test because we didn't go to endpoint on these. We went to 1,000 and stopped and just went, yep, it's greater than. Okay. And then there's a result comment at the bottom, and it's all this, we developed this test and the other things that I talked about before. Pitfalls of definitive tests that you have to think about. Mine are panel tests. As I mentioned to you, I don't have carfentanil on my fentanyl check. I only check for fentanyl and norfentanyl. So if the patient took a derivative that doesn't have a byproduct consistent with fentanyl, it's going to be negative, even with mass spec. These are manual tests. They usually take more time. They usually go to specialty centers. So you're waiting. Then, sometimes it's worth the wait and sometimes it's not. And we understand that. They can be adulterated. So if we get a garbage sample in, then we're probably going to have a garbage output, and we may or may not recognize that. We sometimes catch them and say, "Ew, this is not good." And we stop those and say, really, you should probably recollect this. But if we don't detect it, then it goes out. And then the cutoffs are really low. And sometimes it's a little too sensitive. When we went live with this opioid panel on mass spec, we were catching people post-op 3 days later that were coming through different clinics. And they were like, why is this patient morphine positive? Are they using morphine? And it was like, no, they're just still clearing out morphine. So sorry, we moved our cutoff up as a result. So we tolerate just a little bit of morphine presence because we're a medical center. And that was actually a discussion with Dr. Barry. He's like, I think y'all are overcalling morphines. I said, I think you're right. So we updated that. We partner up quite a bit. So in another setting, like a forensic setting, they would want to know any morphine present, and they would want to trace that and have an explanation for it. And we don't do that. So we just strike the balance for clinical utility on basically every test that we construct. All right, so the best practices finally, consider the setting and the goal of the testing. If you think that there is going to be a medical legal implication to the setup, you need to call us in the lab. If it's starting in the hospital setting, we need to facilitate something that is chain of custody. We need to help you find that testing because it will give you a better level of evidence. We're trying to start some conversations in the system right now about umbilical cord testing because ours is not chain of custody, but at other sites it is. So we're looking at how to standardize that, and should we move to a chain of custody, because we've heard of many cases that have come up in umbilical cords that really could have benefited from the extra level of evidence. But the handoffs involved in umbilical cords there's a lot of handoffs. So it's a lot of record keeping. And so we got to talk about process when it comes to that. Think about your timing, your matrix. Think about what you're collecting, why, what question you're asking the test. Are you asking the right question of the right method? And if you don't know, That's what we're here for. We're here to help match your intentions up to tests. And if you're doubting a screening result, whether it's positive or negative, if it's unexpected, probably a next level test should be considered, especially if there's some kind of implication down road from what this testing gives you. And like I say here, at any point, ask questions. Please ask questions. We definitely want to be here and support the teams. So now we're to Q&A. And I'll put up my thank you slide because it's got my email address and I'm in Epic. And then my colleague, Dr. Yang, Dr. Jambo Yang, he's over autochemistry now. So he and I partner up a lot. He's got some mass spec training as well. So we're here to assist. And with that, I go to some Q&A, and I went a little longer than I intended.
That's okay, Danielle. Thank you so much. It's a lot of information we know, so we appreciate it. Yeah, I'll open it up for questions. There were a couple of comments in the chat while you were speaking, just around like Zantac, kind of seeing it cross-react in our UDS testing and on our pregnant moms. That was from Wanda. Wanda, if you have anything else to add, please, speak up. And then also Laura mentioned that trazodone and causing a false positive for fentanyl.
Okay.
Yeah. So if Wanda and Laura, if you have anything to expand on that, go for it. Danielle, if you don't mind to stop sharing as we're...
I was actually going to show you what I do.
Oh, okay. You're going to show us? Okay. I didn't know if you were pulling something else up. Just wanted to make sure.
Yeah, no. So this is the trazodone structure. This is actually what I do. When I hear about one of these, I go over and I go, yep, plausible, because this is trazodone. Yeah, if I could type, that would be fantastic. Okay. And this is fentanyl. And I can flip back and forth a couple times, but this structure right here kind of is showing up, this little bridge, boop, and this ring and this other ring coming off the top. I could see why it would probably bind with the antibodies. So trazodone. I can put that on our internal little list of things that we look for, because we go into the chart, we look at every medication on the list, we go into notes and see if any other medications were mentioned. Like we dig, and then we go in, we actually look at structures, and we're sitting there like, it's possible. These are things that when I get in the Epic inbox, I'm actually sitting there Googling structures and looking at things in PubChem. So
I have a question. Mm-hmm. Can I just shout out? I was just curious, has anyone ever looked at how many false positives we have with just the first urine drug screening that end up, when you send out for confirmation, not being really, because I'm concerned that lots of decisions get made based on that initial UDS.
Yeah, we know about our problematic screening tests, and we kind of monitor that. We haven't seen upticks. Like, we know amphetamines, it's a 50-50 shot. If you get a positive amphetamines result and it goes to confirmation, it's about 50-50 whether it's going to confirm amphetamine, because there are a few things out there that can cross-react with that. Barb and benzo tests are actually pretty good in how they return. Buprenorphine and fentanyl, because they have very low cutoffs. Buprenorphine's cutoff is 5, fentanyl's is 1, whereas the others are in the, THC is the next closest at 50. Then we have 100 and 200 and 300 cutoffs on these other tests. Amphetamine is at 500 nanograms per mil. That very low cutoff for those two makes them susceptible to cross-reactivities just because of background noise, right, from these other drugs. So we do keep an eye on it. We don't publish it anywhere, but it is something we check.
I think just to speak on that, a basic tenet of addiction treatment is that a screening test is just a screen. I mean, we don't make any clinical decisions based on a screen because, again, we know that there's a lot of errors. So when I see a screen, I use that to talk to the patient like, hey, your screen is showing this. Have you been struggling at all? But I don't base any major decisions on a screen. So we always, always, always confirm. And so when I do hear reports of people losing their kids or clinicians making huge decisions based on just a screen, it can be very worrying because, again, I could be taking trazodone, and we've had staff members that take trazodone, we know take trazodone, and then they've just sort of tested out these tests and they've tested positive for fentanyl. I take cold medicine from time to time. That might show positive for methamphetamines. I can't imagine, my kid being taken away because I had a cold and I took Sudafed that day. But these things do happen, and that's why we base it all on confirmation from a clinical perspective.
I take a lot of antihistamines, so I would be positive for fentanyl right now if I was screened. I don't have children, but it's definitely an education point that it is that step into the doorway. And I get a lot of inbox messages. People are going, could you give me some input here? Could you take a look in the chart? Could you? And certain things that we ruled out from the very beginning. We're like, there is no way hand sanitizer is going to be a problem. We found a case where the circumstance was perfect for hand sanitizer to actually explain a result. And it was like, well, in this particular case, that one worked. So the whole Mythbusters thing where it's like, absolutely no, absolutely yes. We live in a very gray world in here. And so we have to be pretty open-minded about potential explanations for some strange results.
Yeah, and I think that's a big concern when we think of like screening tools in the hands of people who don't necessarily have medical training, like in the legal system, right? Where there isn't necessarily a chain of custody being used in like family court or CPS court, and then decisions being made that affect the lives of entire families based on things that may or may not be accurate. It's almost like, I don't know, it's it feels concerning. And so one of the reasons we asked you here, Daniel, is really to talk about like, yeah, this is a science and we're still learning, right? Like we're still trying to figure stuff out. And it's almost like the test is ahead of us. And we haven't figured out, all the ways in which, it's not just a yes or a no. There's actually a lot of nuance, even though it's a highly sophisticated test.
Well, I mean, I'm preparing a talk that I'll be giving at my annual meeting for all of clinical chemistry. So we've given this talk 3 times. We do it every other year. So that even in my community where people are trained up and we're supposed to keep ahead of things, we're sitting there going, there are trends in licit and illicit drug pattern. The uses of different drugs come up and down. Things come into vogue and out of vogue again, but they're still in the background. New drugs come on the scene all the time, and they're not characterized by these assays. So until we pump it through the system and we end up getting one of these and investigating, we go, oh, okay, that's another candidate. That's one that could do this to us again. So we end up keeping a lot of notes and then trying to share information with each other like, hey, in this particular case, I think this is the thing. We had one patient who was very successful in avoiding alcohol for years, came up with alcohol biomarkers positive a couple times. And it was just like, he swears he's not drinking. He swears he's not doing this. What could be the culprit? And I had to go in and dig pretty deep. He was doing transdermal testosterone therapy. The carrier for testosterone is alcohol. And the best alcohol to put in a transdermal system is ethanol, because you don't want to be absorbing a bunch of isopropanol or some other alcohol. So I said, well, ethanol hit the liver, but he didn't drink. So there's the shifts in therapy as we
so
see.
It's literally like in the liquid that is injected. Okay.
In his gel, because when you do transdermal testo, you put it on a large area like the chest, upper arm, or something like that, and the surface area and the amount he was putting on each day was enough to take him just above cutoff and be positive for ethanol biomarkers. And it was a daily treatment. So yeah, he's maintaining this small positive dose. And I just said, yeah, patients who are in substance use disorder clinics and they're being very vigilant, they might start vaping to offset. How do you think vaping compounds are delivered to the lung? There's alcohol in a lot of those solutions. So these patients come up with weak ethanol glucuronide or ethyl glucuronide results too. And we were just like, holy mackerel, there's the vaping solutions now too. So it's the awareness expands so much. And the checklist that you have to move through clinically is like, okay, are you doing this? Are you doing this? Are you doing this? It's just, it seems very restrictive to the person that, got to rethink therapy, or you've got to accept a certain level of positivity. It's not fun.
Yeah, we had several instances when I was managing a sober living home. We had several instances where individuals were taking psychiatric medications and drinking a lot of energy drinks, and they ended up with false positives for benzodiazepines as well as fentanyl. Depending on the psychiatric medication and the type of energy drink they were drinking as to which showed up as which. And you had to send a lot of those off for confirmation.
Wow, that's interesting. And we had one, I don't know if Dr. Husted remembers this one. I know Dr. Barry would. All I have to do is say the word Thrive, and he would just be like, but there was a supplement on the market called Thrive for a little bit. And it was full of amino acids. There was some caffeine in it, some plant extractives, and some other things. And this patient had come up positive for amphetamine a couple of times. Swore, no, I've been compliant. I feel great. This is the best I've ever felt in my whole life. And it took me days to figure that one out. I said, could you talk to the patient about Thrive? Because I looked in the list of the ingredients. I went through every ingredient in this thing. I was looking at the amino acids, the caffeine structure. I was like, how could this give an amphetamine positive? And it was by mass spec. So it was a definitive test is wrong. Oh. But we were like, well, it's either that the Thrive contains enough compounds that the ions were perfect and got into the right ratio to show up as amphetamine, or because these supplements are not FDA approved and this is an energy thing. What if it was laced with a little bit of amphetamine or a derivative, and it actually was coming up positive for that? So we ended up saying, well, could you just stop taking the Thrive for about 2 weeks, and we'll check clearance and we'll do another urine negative and stay that after the patient avoided that Thrive. It was done. I read a bunch of reports about Thrive, and there were palpitations reported and other kind of stimulant related clinical concerns that were coming up in patients who had Thrive. So I was like, there could be something laced into this compound that we don't know what it is. So definitely the chat about supplements is a big deal. But energy drinks, that's very interesting.
It's one thing I like to consider too, when, if you have somebody that vehemently denies use and you're kind of accusing them of that, you can imagine, like, put yourself in their shoes. If you're doing everything correctly, avoiding this, and then someone who's testing you says, nope, you're a liar, you're a drug addict, you're doing all these things. I mean, that's very discouraging. We've had people that were maintaining their sobriety wrongly accused, and then they kind of get the mindset of, well, you think I'm a drug addict? I'll show you a drug addict. And then they end up dead with a needle in their arm a week later. So
terrible.
It's difficult because, I mean, there are people that kind of skirt around the system and, they get away with things. But for me, if it's a false positive and you take away someone's kid forever, I mean, isn't that a worse outcome than someone getting away with it one time? Usually if people are chronically trying to, like, skirt around things, they will be found out, basically. Like, the testing is good. We test them enough to take, but if it's truly a false positive and you lose your child over it or get incarcerated over with, I mean, that can be a terrible outcome to people and wholly affect their lives. So that's just something to consider too.
Well, it is a discussion point that I give in the talk that I'm talking about giving in July to my colleagues. My colleague talks about unexpected negative results, but I talk about unexpected positive results in this. And I say, he's usually like, you have to be very skeptical. And I say, you might consider believing the person and looking for other causes. So maybe I'm the Fox Mulder in the group there and saying, I want to believe that this story is correct, and I want to try to find an alternative explanation. So I'll do the work. I'll do the legwork, and I'll sit there and look through PubMed and try to find reasons. Not everybody's going to do that. A lot of people are not trained to even know where to look. So that's why we give the talk, is to try to give people a set of tools and a mindset to walk in with: collaboration, investigation, and trying to really come up with plausibility scenarios that it's like, you know what? Probably telling the truth. And this is probably just a hole in how the testing came through, or it was timing. It's something. There was another question.
Well, I was just going to add on to that as well, that, the policy is a drug result in and of itself is not enough to take remove a child. There needs to be a clear sign of abuse or neglect. So we should not, as be making these decisions just based on one or two drug, results of a drug test. There should be other indicators that would lead to that kind of decision being made. But unfortunately, I don't think that's happening from what I hear.
Well,
so which makes it even worse, like when you think of,
Can be, yeah. When we launched the umbilical cord program, this was back in 2014, Dr. Yosick was the driver of the universal umbilical screen program, and I was there with him, and he said within the first week or two, he's like, we're getting too many fentanyl positives. And I said, what are you talking about? And he said, look. So I ran a report, and there were a bunch of fentanyl positives. And I said, it can't be possible that fentanyl is showing up in the umbilical cord that early, like from the L&D scenario. So what we did was we looked at 1,000 charts, we split them between us, and we went back to the beginning of the testing and moved forward in time. So we were tracking this over a while, and we were like, what are we going to do about this? We ended up publishing on it and going, morphine and fentanyl given in the L&D setting can be a source positivity for these things. So you got to be careful with those two compounds in the umbilical cords. And even with a chain of custody, those would show up. So, yeah, that profile is super important, and thinking about the circumstances, especially considering the stigma that would occur with having, pretty good dose of opioids present in an umbilical cord. We just went, wow, that's a big portion of them. So
to translate what Danielle said, if you're a little confused, she's saying literally like someone being given a drug, like you're about to have a baby, you're having a C-section, like my wife's had 2 of them. She's given some drugs to anesthetize her, because you're having a major surgery. It can show up in the umbilical cord, and then a kid could be taken away because screen positive. We've had that before where people were given fentanyl by EMS because they had a seizure in the field, and then someone says, well, you're screening positive for fentanyl, or people being given benzos in the hospital for one reason or another, and then again, a week later, depending on the benzo, may still be present. So these are all factors to consider when we're, again, making these life-changing decisions for people.
Yeah, something I hear consistently in the courts and in the MDTs I attend is a positive is a positive. That's consistently said. So of course that's concerning, but that is very much where our judges are. If it's a positive, it's a positive.
We've had with our CPS cases here in Randolph County, a participant test positive with them through like community corrections, and then they come over directly back over to the hospital for confirmation, and the confirmation comes back negative, and the court still won't accept it because they say a positive is a positive and remove their children.
Yeah, so do we have any judges that have been, I know they're busy people and they have heavy dockets, but some kind of education for them about
that's what I was thinking. Danielle, can you do this talk to the judges? I don't know.
I know that the Dr. Berry had approached me recently about a different kind of conversation about testing and looking at how drugs are detected in antecedents, and then how things are reported. And so I think he's starting to move in that direction. I think he wants to get in front of these high decision makers, because you can advocate as much as you want, but if the bench doesn't believe this story, and I get it, they hear true and false stories all the time, right? And they're trying to work out what's probably real and try to protect children, but it's also, I've seen these discussions, and thank you very much for saying, there's also an emphasis on trying to keep families together. And how do we bridge the science to someone so that they can weigh it better as evidence and consider it at whichever level? Because to me, a positive is not necessarily the positive. So it might be positive, but there could be a very logical explanation that does not spell risk and danger to the children or the family.
Yeah, the judges have an annual conference we're actually trying to get on that agenda, and then we're also trying to provide some education to the WVU law students. So Danielle, if you'd be willing to to provide a little bit of expertise to any education we put forth, we might be reaching out to you.
I think that would be a great effort because, you know, just being in the background and being tapped for a lot of these, you know, what do you think about this? And I'm like, well, I have opinions about the oral fluid testing and how that setting goes, and I haven't ever seen it. And I'm like, well, you know, a lot can go wrong if you're testing a bunch of people at one time. Like if you're generating a lot of samples and you don't keep everything exactly straight and you don't change those gloves every single time, and you don't, like, if you aren't so precise in how you do things, there could be carryover. There could be all sorts of things in the background that could generate an incorrect result, even in a chain of custody setting. If one misstep happens, then someone could be falsely accused. And I want to defend the defensible. So
thank you so much, Danielle, and you know, echo what Amanda said. Great presentation, great discussion from the group. We're almost 3 minutes over, so I just want to be mindful of everybody's time. We really appreciate everybody joining. The recording, the PowerPoint, all that will be coming out in the recap. And our next session is going to be on May 15th, so be on the lookout for more information there. And until then, we'll see you next month. All right. See you, everybody.
Thank you.